Thank you very much, everyone, for coming and for this symposium. So I'm Dennis Falzon. I'm actually not Mario Raviglione. Mario Raviglione is the director of the Global TB program, to which I belong, and we are located at the World Health Organization in Geneva. I come from the world of TB, and I've done some work on, more recently, digital health, and I'll be co-chairing this session.
I'm Jonathan Golub. I am an associate professor at Johns Hopkins University, and I do a fair bit of work. Most of my work is on tuberculosis and HIV, but have been for the last several years also working on tobacco as well. So I'm looking forward to hearing about all your projects.
Okay, so the topic of this symposium is should addressing tobacco use in TB and HIV patients be integral to disease control programs against for support. Without much ado, I will invite Noreen, who's the first speaker. Noreen Mdege is a research fellow with the Department of Health Sciences at the University of York, here in the United Kingdom. Her research covers alcohol consumption, tobacco use, and low and middle income countries. She's interested in individual level and population level health perspectives and approaches to intervention research using both qualitative and quantitative methods. Her presentation is on the prevalence and effect of tobacco use in people living with HIV in low and middle income countries. So, Nori.
Thank you. I just want to say thank you very much for the opportunity for me to present my work today. And the topic is slightly changed from what's on the schedule. I'm not going to be talking about TB patients. I'm only going to be talking about the prevalence of tobacco use among people living with HIV in low and middle income countries. So I would like to acknowledge my co-author Sarwat and Dr. Kamran Siddiqui, who are also helping with this work. And just to say, the project was not funded, and we have no conflicts of interest as far as I know. And today, if we look at people living with HIV, they are expected to live a near normal life, and but there are a number of lifestyle factors that have been shown to be hampering the gains that have been made with antiretroviral therapy. And one of these lifestyle factor is smoking and tobacco use in general. And if we are talking about smoking, smoking among people living with HIV, people living with HIV who smoke have been shown to be have been shown to be at high risk of a number of conditions that are associated with smoking, such as cardiovascular disease, cancers, and pulmonary disease, when compared to the general population or HIV-negative individuals. And if we look at the people living with HIV themselves, those who smoke are at a higher risk of infections and also at higher risk of developing developing AIDS when compared to those who do not smoke. And the mechanisms for these associations, these associations have been mainly attributed to biochemical mechanisms, particularly the impact of smoking on immunosuppression, and also the negative impact of smoking on immune and virological response for those who are on antiretroviral therapy. There are a number of behavioral mechanisms as well that have been suggested. For example, the association between smoking or tobacco use and non-adherence to antiretroviral therapy, but these are not yet well understood. And if we look at mortality, a number of studies have shown increased risk of death among people who live with HIV and smoke compared to those who do not smoke. A study in the US among about 900 women showed a hazard ratio of about 1.5, which was statistically significant. And also another study, which was a prospective cohort of HIV patients in Europe and in North America, about 18,000 HIV patients were being followed up. They found a mortality rate ratio of almost 2. And also another study, which was in a Denmark cohort of HIV patients, showed a reduced life expectancy due to smoking. Actually, the number of life years lost was about 12 due to smoking compared to 5 due to HIV. If we now look at the prevalence of smoking among people living with HIV versus those who do not have HIV or the general population, the literature reports a very high prevalence as compared to those who are HIV negative. Actually, some studies have shown a high prevalence of almost two to four times compared to the general population. The only thing is the literature that is available at the moment is skewed towards developed country contexts. For example, there are now numerous studies that have been published in the USA, which has shown, about 50 to 70% prevalence of smoking among people living with HIV versus 20% in the general population. And these differences are observed for both men and women. There are a few studies that have also been conducted in developing country contexts. And these include a study by Munyati and colleagues, which was conducted among 6,000 factory workers in Zimbabwe, where they observed a statistically significantly higher prevalence within people living with HIV of 27 versus 17 among HIV-negative individuals. There was another study which was conducted in India, where they analyzed data from the National Health Survey. They had about 50,000 observations, and the prevalence of smoking among people living with HIV was significantly higher as well, at 68% compared to 58% among HIV-negative individuals. There are several research gaps within this literature, in that most of the studies that have been published so far look at subpopulations, for example, people in drug treatment or people who are being followed up as cohorts. There is a lack of studies that have looked at developing country context using nationally representative samples and looking at both men and women. And also, most studies look at smoking. And there is less known about smokeless tobacco use and also any tobacco use overall. So to address this literature gap, our study aimed to address two questions. One was, what is the prevalence of tobacco use among HIV positive individuals living in low and middle income countries? And the other one was to get an idea of how the prevalence in this population compare with the general population. We're interested in three outcomes: tobacco smoking, smokeless tobacco use, and overall tobacco use. And for us to be able to answer these questions, we saw the opportunities that is provided by the demographic health surveys, which are nationally representative surveys that mainly collect data on the health and well-being of women of reproductive age within developing countries. And these surveys are usually conducted at 5-year intervals. In some countries, they also collect data on men from the age of 15 to 54, and sometimes from the age of 15 to 59. And some countries also collect HIV status data. And the aim of these surveys is to collect nationally representative data which are comparable between countries. And for comparability, they use standard model questionnaires. And in terms of tobacco use, there are three questions that address tobacco use within these surveys. One looks at current smoking status. The other one look at current tobacco use status. And the other one asks the respondents to identify the tobacco products that they use. And this approach that we took was to, calculate we got data from 28 low and middle income countries, 24 from the African region, 2 from the Americas, one Southeast Asia and one from the Western Pacific. We used the whole regions to classify countries into regions. And for our analysis, we're looking at national level prevalence, and we calculated the crude prevalence and also the age standardized prevalence. And for this, we accounted for the survey design, including the sample design and also sample weights that are used within these national surveys. We also looked at, meta-analyzing the data to get pooled regional prevalences and also pooled global prevalence. For today, I'm going to concentrate on the national level prevalence estimates, the crude ones, and also the pooled global prevalences. I'm not sure if you can see this clearly, but these are the results for tobacco smoking prevalence in HIV positive men. And the point prevalences were really wide ranging from about 10 to about 55%, and the pooled global prevalence was around 24%, and you find about 13 countries, about half of these countries had a prevalence that was above the pooled global prevalence. For smokeless tobacco use in men, you find smokeless tobacco use was much lower than the prevalence of smoking, which is expected even for general population prevalences. And it was also wide ranging from 0 to about 41 for India. Yeah, about 41 for India, with a pooled prevalence of about 3%, and about 9 countries had the national prevalence that was above the pooled global prevalence. If we look at tobacco use overall, we had prevalences from 10%, I think 10% to about 68% for India. So it was really, we had a wide range, and the pooled prevalence was about 27%. And you find about 10 countries at the national prevalence, which was above the pooled global prevalence estimate. We are also, as I mentioned before, we're also interested in comparing the tobacco use in HIV positive individuals against that of the general population. And we used, for the general population prevalence, we used data from the DHS reports, country DHS reports, and were able to obtain 15 country DHS reports which reported this data. And for men, if we look at tobacco use for men, you find that there was an overall trend of the prevalence being higher in HIV positive men than the general population, except for Sierra Leone, where it was the opposite. But then the magnitude the magnitude of the of the difference was much lower than what is reported generally in literature. And for women, you find for smoking, the prevalence ranged from 0 to about 11%, and the pooled prevalence was about 1%. For smokeless tobacco use, the prevalence ranged from 0 to about 16%, with a pooled prevalence of about 2%, which was a bit higher than for smoking. And for tobacco use, the prevalence was from 0 to about 16%. And if we look at the picture in terms of comparisons between tobacco use in HIV positive women and women in the general population, it was a mixed bag really. There wasn't like an overall trend. There are some countries where the prevalence was higher in the general population, and also there were some countries where the prevalence was higher among HIV positive women. So in conclusion, what we know is that smoking has a negative impact on morbidity and mortality among people living with HIV. Most of the data comes from developed country context, but I don't see a reason why it might not be true for developing country context as well. And for the data that I've presented, tobacco use prevalence is higher among people living with HIV than the general population, particularly for men. the difference for women is not obvious, and there are gender differences in product preference, which are also observed in the general population. From my presentation today, the questions that I'm hoping to to discuss will be like: do we know enough to recommend tobacco use, addressing tobacco use among HIV patients as an integral part for HIV programs in low and middle income countries? If we know, if no, what else do we need to know for us to be able to recommend this? And also, if yes, how do we address smoking, tobacco use within this population? Do we address smoking, which will cater for the needs for mainly men, or do we address any tobacco use and cater for the gender differences in product preference? And what would you consider the optimum therapy in this population? Is it the same as the therapies that are used in the general population? For example, can we still use nicotine replacement therapy within this population, even for people who are not on antiretroviral therapy? And there have been systematic reviews that have looked at the effectiveness of treatment within this population, and these interventions used both psychotherapy and also pharmacotherapies, and they observed low level evidence of intervention effectiveness within this population in the short term, but no obvious, no clear evidence of effectiveness in the long term. And considering that this is a chronic condition where people are on treatment, long term, lifelong treatment, what else do we need to do in this population to make those interventions more effective in the long term? Thank you.
So we have maybe time for one or two questions to Nori.
I wondered how your company findings are going to inform the qualitative research that you think we're planning to present today. Which context will you be focusing on, and how your patient perspectives inform the future?
I think there's a lot of need for qualitative research in this on a number of issues. For example, what is happening with women, for example. And is it that they don't use tobacco products as much, or is it that they are not reporting due to the stigma around smoking, and also in terms of the development of interventions themselves. Qualitative work might also help in informing the development of interventions that are acceptable and that work well and that integrate well within HIV programs in low and middle income countries. So there are a number of areas that can be informed by qualitative, because this is an area of research that is still developing. So I think there's there's a need for a multi-pronged approach in terms of research methods.
Okay.
Thank you
very much.
Thank you very much.
All right. I will give a quick second introduction of Dennis Falzone, who's our next speaker. He's a medical officer with the Global TB Program at WHO. Currently, his work is focusing on the WHO guidance for the management of drug-resistant TB and monitoring of the global response to TB control, and also the integration of digital technologies in the implementation of the NTB strategy. And he's here to give us an overview of the rationale underpinning the joint public health approach on TB and tobacco, and discuss how digital health interventions can act as an entry point for joint public health action against TB and tobacco.
Okay, thank you very much. And so my presentation will look a little bit at both the rationale for working jointly on TB and tobacco, and also mention a little bit about some approaches which can leverage the use of digital health technology, E&M health. Okay, I have one conflict to mention, is that our department receives money from the European Respiratory Society to work on digital health since the last 2 years, although this will not influence any way the presentations I will, or the slides I will show. Okay, so let's go a little bit on the rationale for joint action, and I guess many of these principles are well known to you, but they always apply. First of all, both TB and tobacco, they are at epidemic levels in similar countries, in countries where, if you look at this graph, for instance, we just plots here the amount of cigarettes which are sold or consumed by country. Each dot is a country here, okay, in millions, okay, on a logarithmic scale. And if you look at here about the incidence of TB, you see that the high incidence countries sort of cluster, okay, so you get India, Indonesia, China, Russia here, they are clustering around the same point, and there is some sort of linear relationship between the two. Also, tobacco use is the single most preventable cause of death, okay, and TB is the single leading infectious cause of death worldwide, okay, so it has even gone beyond HIV now. So the health benefits of effective public health action against both challenges will be strong. TB is still a non-negligible burden in the world, okay, we recalibrated the incidence this year, so we are at over 10 million incident cases, with about 1.8 million deaths, including among patients for HIV. And an emerging problem which keeps troubling and defying the healthcare is the emergence of multi-drug resistance, even in TB. So you see that every year we have about more than 500,000 cases worldwide which need treatment, which is usually much longer than the standard 6 months treatment. So a big headache. Okay, so coming now on the overlap between TB and tobacco. You see, these are some slides that we had prepared about 6 years ago. But if you look at globally, what is the contribution of smoking in population attributable fractions? Okay, you'll see over here some major sort of determinants of TB, like HIV, undernutrition, diabetes. And if you look at a global level, you'll see that HIV, of course, which is the most potent kind of influence on TB in an individual patient, only accounts for about 16% of the overall TB in the 22 high burden, those countries which had accumulated like 85% of the global burden of TB. But if you look at, let's say, smoking, it even exceeds that amount. So on a global level, you'll see the importance of tobacco. Similarly, for instance, undernutrition has a much bigger contribution globally than HIV. Okay, smoking is associated with a number of determinants of TB, infection, active TB, severity, death, and even recurrence. Some even think that it might be associated with drug resistance as well. And also we know that smoking cessation can reverse a number of those adversities. Both TB and tobacco, prolonged patient adherence and support are required for a lasting effect. So this is something else which is in common with the two diseases. Okay, both TB and tobacco are primarily associated with respiratory pathology. Okay, so very often it's the same specialists and the same clinics which are dealing with these patients. And so population level action to improve outcomes for TB patients can be useful in both low and high incidence settings. Okay, so now I'm trying to present a little bit about how the strategies that we have for TB. I come from the TB side, okay, later there will be my colleague from WHO as well, Dongbo, who will present the side more from the tobacco side. But the NTB strategy is the post-2015 strategy, if you want, for us to try and control the TB epidemic in the next 20 years or so. So we have these targets which we want to achieve by 2035 with milestones in the middle. And the strategy is sort of oriented over three different pillars, we call them, okay, which are shown here horizontally. And of those there are about 10, within those there are about 10 components. So you have one which is targeted really at finding patients and treating them, TB, okay. Then there is another part which is probably much more pertinent to the subject that we are discussing over here. It's about having policies to make sure that there is a more sort of, how would you say, holistic and approach towards limiting the adverse effect of the determinants of TB. Okay, so, and in this area, this is the space probably where we can insert action against TB through working on tobacco. So there are a number of entry points which one can think about how to approach the issue for the two conditions. Okay, one of them could be at the patient care level. Okay, education, reminding patients, okay, about the importance of the TB patients, about the importance of stopping smoking, and vice versa about patients who are smokers and who have sort of persistent symptoms, which sensitizing the healthcare workers to the symptoms of TB, because it can be a case of TB which is masked behind a chronic obstructive pulmonary picture. Apart from that, there's communication to the public and professionals, okay, training of the healthcare workers, monitoring policy implementation, and creating tobacco-free environment in clinics. So these could be approaches toward joint action. Now, if you look at the two populations of TB patients and tobacco users, digital health could be one way of getting into this, because, for instance, if you have health messaging, okay, one means of doing the health messaging could be through, let's say, SMS sendouts, right? So I think Kamran will present some of the work that he is doing with other colleagues in WHO on that. Similarly, for instance, e-learning for healthcare workers, you can do it very effectively using smartphones. Monitoring and surveillance data, okay, is an area of overlap, etc., and so on and so forth. So, and we've mapped a number of these. These are the same strategy components that I showed previously, and here, for those who can see, there are potential sort of digital interventions which can help. So, for instance, things like not just SMS communication or notification of TB cases, but also providing credit, for instance, for patients who want to or who manage to quit or who adhere to the appointments for TB treatment. And likewise, VOT, video observed therapy, whereby the observation of patient doses for TB treatment comes via smartphone applications, is increasingly being used, and through that medium you can also deliver health messages on smoking, on HIV, on general health education, etc. You will find many of these infographics, if you want, in some of the publications we produce on digital health. So you'll find some copies, also paper copies, in the booth of WHO downstairs. Okay, so you can, if not the PDFs, you can find them online as well. Okay, so one of the things which is important, I think, is the evidence. The evidence base for digital health interventions varies hugely. For some, there is practically no evidence as we know it, right? Where you have randomized controlled trials. So if you look, for instance, for evidence for electronic data management for TB patients, it's very sparse. Okay, there are best practice narratives and descriptions. You'll find quite a bit of that. But however, comparing that with a paper-based system and how the relative benefits at the end of the story turn out to the patient or to the services are not well sort of constructed. There aren't studies made like that. On other areas, like such as SMS, VOT, there is a science which is slowly building up. But what we want is really to have these concepts and products, you know, tested out, preferably in patients with TB or TB tobacco or whatever other condition that you have in mind. And then the evidence becoming available as studies, okay, and helping us as WHO and other sort of agencies to produce policy which is based on evidence, okay. The other question is, how scalable are they, right? Because you could have something which works very nicely on a small pilot in a few clinics, but then when you try to scale it up at a country level, it doesn't work, or you need huge amounts of input and resources to keep pumping it up and keeping it alive. So I think this concept is very crucial. However, if you look, for instance, one of the encouraging things about scalability is the huge expansion in the availability of both internet as well as cheap hardware, which allow patients and healthcare workers in many parts of the world nowadays to connect onto the internet. So, and this graph just shows you the smartphone connections and the adoption globally going into 2020. And to know that much of this drive is actually fueled by developments in places like India and China. Okay, so it's really taking off, and it's taking off because of these developments in these countries. So 3 scalable interventions which one can think of is, one of them is SMS, okay, the use of texting in different ways to try and change behavior or change information or the knowledge of healthcare workers. The other one is video observed therapy, okay, and electronic medication monitors is another one. So these are primarily things which have been tried out in a number of different settings and where we feel there is good likelihood that they could be scaled up. So the evidence is still developing in these areas. So that is just an infographic to show you the how SMSs are used. They are used in very different ways. Okay, no 2 studies are the same, I think, but very often they are used as reminders, which have very limited effect. But when you use SMS in a 2-way system, the evidence seems to show that they are more effective. Another one is video observed therapy. This is one product. There are more being developed. Okay, it's a smartphone application. Nowadays they are becoming very easy to use, even for people who are illiterate. They just need to push a couple of buttons. Okay, so even people who are visually impaired, sometimes they can even handle that. Children can even do it, is being shown. And the other one are the medication monitors, okay, which send you an SMS if the patient doesn't open a box every day, as they're supposed to do in TB practice. Okay, so the evidence, as I said, is still developing. So for SMS, there were 4 RCTs, which for TB in particular. However, we have up till now no significant effect on cure and completion. And this is probably because of the way they were designed, more as sort of one-way reminder sort of system. Video observed therapy, we have 2 observation studies as well. No significant effect up to now, but there are RCTs which are, one of them is about to be published, and the other one is starting now, and there will be more. And from initial findings of the first one, we feel that there are going to be quite promising outcomes. And medication monitors, they are coming up as well. There is one RCT reported last year. However, it did show no statistically significant effect, but one observation study in the past had an effect on cure. So still, we are early days, I think, with the evidence. However, it should not stop, I think, people from investing and doing more research in this area, because things keep changing, technology keeps changing, and the application of these products could be more creatively used. Okay, so about mobile phone interventions for smoking cessation, I leave a bit more detail for Dongbo to cover, but there has been a systematic review updated last year with 12 RCTs or quasi-randomized trials, okay, and there were large variations in design. Again, predominantly it was SMS based, sometimes jointly with in-person visits, okay, and most of them were done in rich countries. However, the pooled effects for that did show that those interventions did have a statistically significant effect on abstinence. You know, whether this would be long-term, beyond 6 months, it stands to be seen. But you can see that there was quite a significant variation in between the studies. Okay. Okay, so this is the agenda that we produced for TB last year. So you'll find some copies of this in the booth, and there's more detail in this paper which came out earlier this year, where we listed the target profiles, which are briefly discussed over here. And that document is much more comprehensive. It's open source. Okay. Okay, and this is, I think we're running out of time, so I think I'll draw the line there. But giving you the website, okay, you can grab the QR code. You have that one on your mobiles. But on that one, you'll find a bit more information, some more publications that can give you a bit more information. Okay. All right. So I think I'll just leave the last conclusion, because I think it's important that we look at the evidence, you know, but we need to ask as well, how much evidence do we need before we start rolling out a particular intervention, okay, and how many studies are necessary, and what type of studies as well, okay, because I think one risk would be that there might be opportunities, and just because they have not been studied yet, there is no investment on them. And this is one of the reasons that we have put in place this target product profile approach, so that we can steward the number of interventions which show promise, but where the evidence is still sort of in its infancy. And that way we can maybe, you know, steward them and drive them to a completion of the studies. Okay, so I'll stop there. Thanks very much.
Time for 1 or 2 questions.
Yes, go.
Dennis, thank you very much for championing addressing tobacco use in TB world, particularly in WHO. My question is that one of the things that we've been lobbying for a while is basically TB people recording smoking status. So a lot of TB programs, when we talked, they said yes, we want to, but we want a clear direction from WHO. So I don't know if there is anything you heard in the TB world in WHO that's moving in that direction.
Right. Well, I think, given that there is this, the strategy itself is this anti-TB strategy is very much focused now on, and I think I could actually explain the graph which I showed, which I did not really explain. But this would be the graph, if you want, of the incidence that we'd like to see. Okay, so this is the incidence as it is in around 2014. Okay, when this was the baseline was created, and you can see that there is the incidence of TB is going down, but it's going down really slowly. All right, and what we want to see is that this is 2035. So this is where we want to get post 20 years post 2015. Okay, so that would come down to levels which you find nowadays in rich countries. Okay, so we want to have all the countries of the world reaching that level. Now, if we don't do anything and just assume that the current negative trend continues, we'll be only there in 2035. Okay, so to bring it down there, first of all, in the first 10 years, we need to drive it down very fast on the assumption that we will not have any significant new treatments, certainly no vaccine, okay, for TB. And to do that, what we need to do is to do things better that we have done, right? So make sure that we find more TB patients, we treat them, we make sure they stick to their treatment, you know, we should make sure that there is less emergence of drug resistance, and so on and so forth. So digital health would be particularly important here, right? Because if you're talking about making sure patients are adherent better to their treatment, these tools maybe can help, right? If we want to make sure that diagnostics give us information very quickly, okay, and everything is digitized, then we really need digital tools to invest. And things like, for instance, studying the effect of smoking will probably be needed, because if we really need to take this dip, we really need to do a population level intervention and make sure that things like that I showed in the previous slides, like smoking, okay, like nutrition, like HIV control, alcohol consumption, and so on and so forth, varying depending on the local epidemiologies, are addressed at a population level. So I think having the information, okay, would be important. And actually, if you, even though it's not the smoking status is not one of the what do you call them, variables that you have in the standard paper register, many countries which have electronic recording and reporting would have some information about smoking. Now, very often the problem is that it's not standardized, because some of them might have, for instance, do you smoke or don't you smoke, with no information for those who don't smoke whether they used to smoke. Also about the amounts of smoking. This granularity varies by country, and but we would want countries, we always tell countries to try and collect this information. They even collect it very often when they are doing one-off surveys, let alone the routine, like for instance drug resistance surveys.
Thanks. Clearly the surveillance aspect is very important, but it's also a prompt for health professionals to then start a conversation about cessation. So I think it is sort of dual benefit.
Yeah. Clear.
Thank you. We have Cameron, are you next? I'm not sure of the list, the order here.
Yes, so I need to.
Right.
It's the same list.
Yeah. So next
okay,
is Cameron Siddiqui, who many of you here know. He's trained in medicine and public health, and he has a research group interested in lung health at the University of York in the UK. He chairs the tobacco section at the union. There was a very nice working group meeting this morning. His research interests include the interaction between smoking and infection, secondhand smoking, and smokeless tobacco. And he's currently leading a major European Union funded research consortium on TB and tobacco in South Asia. And today he'll talk to us about some innovative health interventions targeting TB and tobacco use, supported by WHO.
Thank you, Jonathan. Thank you, Dennis. So this presentation is actually was supposed to be delivered by Dr. Sarabhi Joshi, who's a technical officer for WHO, and as you can see, I'm not Dr. Joshi. But I'm very proud of and very happy to be part of a WHO group that's actually developing this intervention, and particularly happy because some of us have been lobbying for integrating tobacco into TB for a long time, and this is clearly one of the answers, and very positive answers from WHO, to develop a digital intervention to integrate TB and tobacco together. I think one of the things that we should also recognize that this initiative was started while WHO is being the main driver, but one of the catalysts was European Respiratory Society that was part of the initial sort of stimulating this initiative. So where this initiative came from, the year 2011 was very important for NCDs, and I think most of you know why. This was the time when UN has very few issues that actually UN had an assembly on one single issue, and within health, I think the issue was non-communicable disease. So I think world coming together and realizing that 9 million people dying prematurely because of non-communicable disease, and billions and trillions of US dollars being spent on non-communicable diseases, and we don't even have a united global strategy to address NCDs. So this was a very important moment for people who are working in the NCDs, people who got NCDs or suffering from NCDs, that the world has got together to address NCDs. Something else was happening at that time. The number of mobile phones was reaching just almost the same number as the world population. So I think some clever people in WHO thought this is a great idea to try and combine these two things that are culminating together and use this as an opportunity for using digital technology to do something about NCDs. So out came this program called Be Healthy, Be Mobile. And the core operations of this program that WHO leads is developing a toolkit, and then they are implemented in countries, and obviously developing a partnership between people who are working in the health, people who are working in the IT systems, and developing a whole infrastructure to deliver it. And there have been a number of initiatives. So obviously we're talking about TB and tobacco here, but there have been a number of initiatives including M-diabetes, M-tobacco cessation, which I hear that is implemented or being implemented in India at the moment, M-hypertension, M-cervical cancer, M-COPD, chronic obstructive pulmonary disease, M-aging, and M-TB tobacco. So we're going to talk about M-TB tobacco. So what is M-TB tobacco? Before I talk about M-TB tobacco, this is a repeat, I know, but I don't feel ashamed of just repeating the link between smoking and TB patients, just to remind ourselves that people who smoke have got a severe form of TB disease. They've got more cavities, they get hospitalized more, their culture remains positive for a lot longer, their treatment adherence is poor, they've got unfavorable outcomes, there's more deaths if people smoke, and there's about 17% people remain unsuccessful in being treated for TB, and there's a higher relapse rate as well. So just a reminder. Anyway, getting back to M-TB tobacco toolkit. So our target population is TB patients who smoke, and the intervention is a set of SMS messages to stimulate a change in smoking behavior and also to support TB treatment. Now the second bit is very important for us. So we didn't just want to talk about smoking behavior, we wanted to look and address a number of different aspects of human behavior that are directly linked to TB treatment outcomes, and that was very important. And the outcomes, as you see, are not just success in quitting, but also in completing TB treatment. So it'll become obvious that why we have those two outcomes as a prime driver. The audience for this toolkit is primarily TB program managers, but obviously it doesn't include just include TB program managers. It includes people from other health and ICT sectors, and obviously other academics who are interested in this, and other national partners, because as you know, the TB program in certain countries is not just delivered by national programs, but delivered by a lot of voluntary sector organizations as well. And the purpose for this toolkit is to lay out a standard operating procedure which will support implementing the MTB tobacco program in different countries. So when you actually, I mean, this is just a generic slide, but when you're actually developing a text messaging program, there are certain things that I think are being recognized, and there is a group that does that, and they've sort of laid out certain guidelines, certain steps of developing a text messaging program for any health issue. The first thing you need to choose is the behavior change goal. So what is the goal here? And so for example, smoking cessation in a particular group could be the goal. And then you choose what is the objective of your communication. And so there could be a number of things. Sometimes you're just giving knowledge. The objective is to provide knowledge because there's no awareness, so you're just providing knowledge. Sometimes you're actually challenging held beliefs. Sometimes you're challenging what is the existing norm. Sometimes you're challenging certain attitudes. So I think you have to be very clear. It's not always about knowledge. A lot of times it's actually challenging deeply held beliefs, misconceptions, myths. So I think that understanding is very important. And once you've done that, then the actual design of the framework involves timing and frequency of messages and how you use different keywords in that. Then you get up and write the message library. So the work started with a global workshop on M-Health for TB and tobacco, which was led by WHO. I was privileged to be part of that workshop, and also European Respiratory Society, who were one of the partners in this. One of the very interesting aspect of this workshop was that we did something slightly different. So normally we have a very healthcare or health professional focused approach, but in this one we had a patient-centered or a human-centered design approach. So we looked at the life course of a TB patient, and right from the start thinking that, and we had different scenarios. So people from different parts of the world, they were their life stories, and we went through the life stories and we looked at the opportunities where our text messages could be used and could be helpful. And that was quite a different way of writing text messages, rather than saying these are the set of information, this is what patients need, we should just send these messages out. No, we didn't do that. We actually looked at, or tried to at least look at, from the patient's perspective. So what are the broad categories of our toolkit? Some of course is information based, because there is very poor awareness of the relationship between smoking and TB. So some of the information that's going to go out is based on information. But then there is a lot on motivation, motivating people to quit tobacco. Emotional support, as you all know that TB patients are vulnerable, and it's quite a devastating thing to have. So therefore some of the messages are based on emotional support. We all know that in countries that we work in, people are stigmatized and discriminated against because of TB. So we need to directly deal with that and try to address that, and again doing that through SMS messages is part of that. Treatment adherence is a issue for TB patients, obviously, who would like to take horrible medicines for the period of 6 months, but we ask patients to do that. So therefore least we can do is to provide as much support as possible in making that happen. Prevention during treatment, so how to prevent transmission of TB while they're being treated, and also prevention after treatment is also part of our messaging system. And then obviously other health and nutrition aspects are included. And then a lot of patients actually do want to share their TB story with others. So I think that was also part of not only getting social support from their families and friends and neighborhoods, but also sharing what's happened to them and what's been the impact of TB on them is also shared in a positive way. So that's also part of our category. So just to give you a few examples, I'm not going to tell you all the 160 messages that we wrote, but just to give you just a few examples. So the starting point for us is this target behavior. So please don't look at the SMS messages just yet, but look at the target behavior. So smoking prevention, cessation, and seeking social support. And you can see that some of them relates to lack of knowledge, some relates to myths and misconceptions. So let's just pick one. So lack of knowledge. A smoker is 3 times more likely to catch TB germs than a non-smoker, and this is addressing a knowledge gap that would hopefully directly target a behavior which is smoking cessation. And this is and the technique that we're using is providing information about health consequences. So let's look at something else. TB patients can live healthy, normal, and productive lives. So the target behavior here is seeking help and medication adherence. And a lot of times this doesn't happen. The barrier is that there is poor self-efficacy, and therefore the technique that is used in these SMS messages is persuading people about their own capability to address this issue. So the contents of the toolkit are, there's a lot about operations and management. So how to set up a steering group, for example, how to bring different partners in a country together to implement it, and then go on to develop the contents and how to adapt the messages that we've developed to the country context. Then some of the technical specifications of implementing services, because this is going to be implemented at a much bigger scale through IT systems. IT systems need to work together with the TB systems, so there's quite a lot of technical help in that toolkit. And then how to promote this program and invite people to recruit into these programs, and then there's monitoring and evaluation. So what are the next steps? We are hoping that by the end of this year we will have a finalized toolkit of MTB tobacco, which will be pre-tested first in Egypt in the first quarter of next year, and I know that India is also committed to MTB tobacco program implementation next year. There'll be a meeting later on in December in Cairo, because EMRO, is part of WHO, has been very, very supportive of this initiative. So they've hosted the first conference, and I think they're hosting this meeting as well. What we need is, for implementing an MTB-TB program, is political commitment and your enthusiasm, but the rest is provided, the technical help is provided by the toolkit, and that's what I think WHO does. They provide the technical support and expect health professionals and people to provide the enthusiasm and seek political commitment. And if you want to learn more about the technical side or the design of this program, then the person to go to is not me, is Dr. Joshi, Surabhi Joshi, who works at the WHO in Geneva, and she's very sorry. I know she's been looking forward to it, but she's very sorry not to be here. But she said she doesn't mind being contacted if you want more details about this program. Thank you.
Thank you. Question?
The software itself is available freely, or you have to pay something?
No, you don't have to pay anything.
Okay, so
Yeah.
it's free of charge.
Yeah. So the
finalized. I mean, it's already fixed, the finalized version, or it's under construction version.
For MTB tobacco, it's being developed at the moment. Yeah, but for all the other, I've talked about diabetes and other things, it's already there on WHO website.
Is there any user guide?
Yes, yes, that's exactly what we are producing. User guide and a message library and. Yeah.
Please, yes.
I'd like to commend the initiative. It looks a bit cost effective. Yeah. But however, I'm concerned about the population of low or of no literacy at all, as to how the toolkit could be modified in order to suit their needs.
Yeah.
Because I'm from South Africa, and I've just been, I'm currently carrying out a survey with drug-resistant TB patients who smoke. So far, I've done about 55 questionnaires, and within that number, there's more than half of them are of very low literacy, and they had to be assisted, even with the questionnaire is in their own local language, you know, because they cannot read comprehensively. However, that they do have mobile phones, and now I'm wondering how we can use that opportunity in order to include their needs as well. While it can work very well with regard to young people, could be, I feel that it could be quite useful. However, with the older population, which is however, maybe there could be some means of overcoming that, like getting pictures or a short video or however.
Yeah, no, that's a very valid point, and I think the group that's developing it is very conscious that it has to meet the needs of people who are using it. So therefore, there is a component within the toolkit which is about needs assessment, and I think we very strongly recommend that before implementing this program, there has to be a needs assessment which needs to take place, and this is looking at the needs of the TB patients so that this program can be adapted appropriately to the needs of the. So this is as a guidance for developing and implementing a program. It's not the final version. So I think there will be a piece of work that needs to happen in each country. But obviously WHO through this toolkit and also through their team would provide technical support in doing that. But needs assessment is a very important part of that program.
Okay,
Thank you
very much. Okay, so I invite the next speaker, who's Dong Bo-Fu, who is a technical officer for tobacco cessation in the National Capacity Building Unit of the Department for Prevention of Non-Communicable Diseases, which was previously the Department of Tobacco Free Initiative at WHO headquarters. Dong Bo, he has over 10 years of international country-level experience in tobacco cessation and treatment of tobacco dependence. He is the WHO principal focal point to support member states to establish and strengthen their national tobacco cessation. It's the one before the last. This one. Yeah. To establish and strengthen their national tobacco cessation and treatment systems, including TB and tobacco control integration in primary care. Sorry. Okay. Give us a second because we have to do the technical thing here. Yeah.
Sorry, I'm not able to find my slides.
Yeah.
But, good afternoon, everyone. Thanks for Dennis for a nice introduction, and also thanks the union actually give us this opportunity to talk about TB, tobacco, and HIV integration.
That's not this one, right? So you uploaded it?
Yes, yes.
Let me see if I have it still on the.
That's interesting. Disappear.
In the Dropbox.
It's in the Dropbox, huh?
This one? Is this one not?
No, that's from Noreen.
Mine as well.
Excuse me a second, I'll try to recover it from the Dropbox.
Actually check. So let's continue. I actually have been attended the union conference regularly, so it's very pleasure to be back again to talk about TB tobacco integration. Today I will mainly focus on talking about the WHO, the union recommendations, and the country experience about TB and tobacco integration in primary care level, which is more adopting like a health system approach, and what the health providers can do as their routine practice in terms of supporting TB and tobacco integration. So you will see this since has already some information has already presented by Dennis, and because we did the work together. So here we mentioned WHO is WHO Tobacco Free Initiative and also WHO Global TB Program. So WHO and the union started to collaborate on TB and tobacco issue in 2007. So in 2007, we jointly conducted a qualitative systematic review to see if there really a relationship between tobacco use and TB. So we conducted this review, which actually confirmed there is a causal relationship between tobacco use and the TB epidemic, and also this work laid the scientific foundation for the joint actions to tackle the two global epidemics. So very quickly to show you the results of the review again, which indicate active smoking or exposure to secondhand smoke is significantly associated with TB infection and TB disease. And also active smoking is really associated with the recurrent TB and also TB mortality. So this is the results. And based on this, and also we look at the population level impact. Dennis already mentioned. Here I presented the results about the 2009 estimate. So you can see in 2009, if you look at 22 high burden TB country, you will find 23% of TB cases actually can be attributable to active smoking. And this gives us an idea about how tobacco control can help control TB epidemic. So in general, we will agree. So if we're able to stop smoking, which actually can help or has the potential to prevent about 20% of the all TB cases in the world. So that's a great population impact in terms of the benefits we can get from tobacco control. And emerging evidence also support if we help TB patients to quit smoking, actually will have positive impact on their treatment outcomes. So here I just give you one example about the study conducted in Malaysia. It shows compared to those who only receive the dose treatment, if we provide smoking cessation intervention for those who use tobacco, you will see their treatment failure and treatment default actually are decreased significantly. So you can see the benefits on treatment outcome as well. So you can see the TB treatment program or the National TB Control Program will have great benefits from tobacco control. But actually on the other side, the National Tobacco Control Program also can benefit from the TB program. The reason is the National TB Program actually can help reach a large number of tobacco users per year and also support them to quit. So I give you two examples. One example is about the DOTS program. The DOTS program actually has the potential to reach more than 1 million tobacco users per year. So this can be easily understood if you look at the recent global TB report. You will see there are about 6 million new TB cases notified under the DOTS program in 2015. So we already know from the first speaker, the prevalence of tobacco use is much higher among TB patients compared to those in general population. So we even assume only 20% of them are using tobacco. You can see the DOTS program can reach 1.2 million tobacco users per year. So you see the large number of people we can reach. Another stop TB strategy we call practical approach to lung health can have the potential to reach 20 to 30% of the patients in primary care level. So you can see the National TB program can help. National Tobacco Control Program is really to increase the reach of tobacco cessation service for tobacco users. So considering we have scientific evidence showing there is a relation between tobacco and the TB epidemic, and considering both the National TB Program and the National Tobacco Control Program have mutual benefits from the joint activities. So the second phase of the WHO, the union collaboration, actually was to develop some recommendations on the joint activities, the joint tobacco control activities, which the managers of National TB Program and the National Tobacco Control Program can plan and implement. So you can see here, in clinical setting, 3 types of actions has been recommended, which are: first, we need to provide treatment of tobacco dependence for TB patients. Second, we need to make the primary care facilities where TB patients are treated smoke-free. And third, it's very important, we need to promote system change. We need to take managerial decision to overcome the barriers in the health system to institute the treatment for tobacco dependence. So these are 3 actions. Many can be done in clinical setting. So with this one, since we are talking about many helping smokers quit, so I'd like to give more information. What kind of intervention, what kind of treatment are recommended for TB patients? So it was recommended that all smokers who are being assessed at a primary care center for TB or other respiratory disease should be identified and at least provide brief advice routinely for them to quit smoking. So this is something we need to pay attention to. Many people say, oh, I cannot do more than 3 to 5 minutes. Although we have like regular contact with TB patients within like 6 months, right? But at least 3 to 5 minutes brief advice as part of their routine practice for our TB care providers is feasible. So we will show you later on according to the country experience. So this is a recommendation. At least 3 to 5 minutes brief advice should be part of the routine TB care. So based on this recommendation, since 2007, WHO working together with the Global TB Program, WHO has been providing support to several member states to implement the WHO, the union recommendations on TB and tobacco control integration in primary care level. So the first country is Nepal. Nepal had successful experience of integrating brief tobacco intervention into POWER approach. The POWER approach is a practical approach to lung health. You know that this is like a patient-centered approach, mainly to improve the quality of care for all respiratory disease patients in primary care level. The purpose is to improve the TB diagnosis and care. So the POWER actually is an existing program in Nepal, initially in 2001. So between 2007 and 2008, integration of brief device into this POWER initiative was completed in 2 districts of Nepal as a pilot project, as a WHO pilot project. You can see here at least some activities we have been done under this project. You will see, based on the recommendation, we actually achieved integration through like several system interventions, not only training health providers, which is something very common, but also like change the governance leadership. For example, we secured support from policymakers. We also changed the POWER guideline to include tobacco control efforts and also information system. Cameron mentioned very early said, it's very important you need to change something in the information system, or else the healthcare providers may forget to do that. So we did something like we integrate smoke status into the POWER register in Nepal. So this will serve as a reminder tool to remind health providers every time need to ask and advise. So you can see this is system approach to achieve the integration. The results I reported several times. It's quite encouraging. So according to data from just one primary care facility, you will see the prevalence of tobacco smoking among those respiratory disease patients presented to the primary care facility is very high, it's around 60%. 60% of them are smokers. So among them, the brief device has been routinely given to 22% of them. And among those who received the brief device, 23% of them were able to quit smoking for like 6 months. So this is quite encouraging. And based on the success of the pilot between 2007 and 2008, integration of brief device with the POWER initiative actually expanded to 25 districts of Nepal in the last 5 years. So you can see the good impact or the progress that we made in Nepal about the integration of brief devices into POWER approach. So the second country is India. India, I know we have colleagues from India. This is a very good example to show India had a successful experience of integrating BreathWise into another approach, is a DOTS program. In 2010, BreathWise for tobacco cessation was incorporated into the ongoing TB treatment program in one district of India. And for this project, totally there are about 2,800 tobacco users, including smokers and smoked tobacco users, registered for DOTS program. Will offer the BreathWise, and at the end of treatment, at 6 months, the end of 6 months treatment, about 67% of them actually were able to quit successfully. So the quit rate is quite high. And this is a very good example to see even very BreathWise. For some country, the patients were not able to receive any support before, actually can get a quite high quit rate. And between 2013 and 2015, with the financial support from the Ministry of Health, Labor and Welfare of Japan, WHO actually continued our technical support for 4 more countries for them to integrate BreathWise into DOTS program. The 4 countries are Cambodia, India, Nepal again, and the Philippines. And you will see within these 2 years, we have like about 800 TB patients received the BreathWise, and around 32% of them, 2% of them actually were able to quit successfully. This is 3 months follow-up, not 6 months. And most important, this project has actually benefited about 5,000 patients with respiratory disease. They also received the BreathWise, and about 20% of them were able to quit successfully at 3 months follow-up. So you can see the example, all the country experience clearly shows integration of TB and tobacco control in primary care level is feasible and effective. And WHO also have developed a series of technical tools and materials to support the country to implement the WHO and the Union recommendations in the last 7 to 8 years. But at this moment, you will see most of the countries are still implementing this project as a pilot. So only covers a few districts or provinces. So for the next step, we'd like to encourage more countries will consider to implement this recommendation to promote TB and tobacco control in primary care. And more countries are willing to consider to implement a nationwide project covers the whole country in order to get like maximum benefits for controlling the TB and tobacco epidemics. So that's what I will share with you. Thank you very much.
Please.
Yes.
Yeah, thanks for the information. One question I've got is, with the DOTS program in India and the Philippines, you talked about the patient ceasing smoking.
Yep.
Was that active and passive smoking, or were other people in the household still smoking, and so the patient was effectively passive smoking?
We only adjust those who active smokers. Yeah, they come to the primary care facility for treating TB diseases. Yeah, it's like opportunity innovation. When you come to your healthcare provider, they give like a very BreathWise repeatedly.
So although the numbers look very good, they may not actually be as good because they're still passive smoking.
You're right. Probably, yeah. I won't say I will exclude this possibility, but I think you see the impact is like around 800 of them actually quit successfully, and it will reduce the chance of like for their family members to be exposed to second smoke.
Yes, but if the family members already smoke, then they're still being exposed to passively.
Yeah, probably
so
yes.
it's not going to be quite as good a result as one might think.
Right. I think I like your point. I'll just say the work we have done here need to have some kind of context. The whole country need to continue their comprehensive tobacco control efforts, including reduce the secondhand smoke exposure. Yeah, but here I think we only focus on what healthcare providers can do when you have some time with your TB patients and you know who is smoking.
I think it's a very good point. I think, however, I would take both sides of the argument. First, I would say getting the patient to quit smoking is a wonderful thing, and if you can get them to quit, even the exposure to secondhand smoke is considerably less than the exposure from their active smoking. And also it calls into play the idea that we should be looking into getting the families and the peer groups to contribute to help out with the smoking cessation and try to extend the lessons to them as well.
Good. Yeah.
A lot of questions coming up.
So in terms of the smoking cessation intervention documents, you have mainly, of course, there's several, but WHO, you published the BTI, and then facilitating rapid enhancing, and then also the BTI for TB control documents you published. And on the other hand, Union, published 2008 ABC. So in the health promotion side, backed up by WHO, they facilitate such BTI, brief tobacco intervention.
Yep.
Yeah.
Yep.
5A, 5R.
Right.
So, but on the other hand, the TB side, they back up Union.
Okay. Yeah.
They try to.
Thank you for your comments.
So it is a kind of conflict.
Yeah. First, I would say, from my point of view, it's completely consistent. It's like someone wants ownership. I want ABC.
I don't agree.
Okay, let me explain. If you have comments,
yes.
It's completely the same. We say 3 to 5 minutes brief voice. The idea is spend 3 to 5 minutes talk to your smokers about quitting. Whatever you did, evidence shows. No difference. You use ABC AAR model or a 5A model. But where WHO used the 5A, 5R, it summarizes everything you can do clearly. ABC, if like C, cessation support, you still have like a system to make quit attempt, refer them to like existing cessation services, and you have other things. It's really like how you summarize the activities. And by the way, the first union guideline use 5A, 5R.
Yeah, that's they switched. I know.
Yeah,
So
it's to change the model because people want to summarize differently. But to me, 3 to 5 minute innovation, whatever model you are using, the same. They are all effective. Yes, please.
Okay, I think,
One
yeah,
more- one more
okay,
question.
very quickly.
Thank you for interesting presentation, and the quitting rates are really quite impressive. I was just wondering when the follow-up assessment of quitting was assessed, and was it a one-time assessment or you did like several assessments just
Yeah.
to see whether the rates are consistent?
Yeah, actually, like TB patients with health provider, they have regular contact within 6 months, right? We only ask them to report after quit date, the 3 months. For WHO, we have limited time because we have to report to donor. So for us, it's 7-day point prevalence abstinence rate at 3 months follow-up. Thank you.
Okay, thanks very much, Longo. So with that, I will invite Sonu Goel to present. Sonu Goel is an associate professor at the School of Public Health in Chandigarh, India. His presentation focuses on the scaling up of integrated interventions for TB and tobacco integration and the mobilization of resources at a global level. Thank you very much.
Okay, thank you, Chair. Sorry, my title is Impact of a Smoking Cessation Intervention Package on Treatment Outcome of TB Patients in North India. It's a clustered randomized control trial, and I was listening to a presentation and wonderful evidences which was there by the previous speakers on how TB and tobacco as are so correlated to each other. One is risk factor, which has been confirmed by many studies. So what I had tried to do is, as there was a discussion on ABC package. Yeah. So as there was a discussion on ABC package, like how effective that ABC package is in quit rates. So it not be surprised that after seeing the results, that it is even more effective as compared to the other studies which we have seen earlier. So we know that the TB is the world's deadliest communicable disease, and there is a risk factor. This tobacco is a definite risk factors for TB, as I think in this session we have been already documenting this. So, but we have limited data from India on the effect of smoking cessation on TB treatment outcomes. As in other countries also, I was just searching out, there was not many data which says that there is a definite evidence that if we give a smoking cessation package in any form, whether it is 5A, 5R or ABC, has a definite role in quit rates. So we try to do a stronger design. Before that, we just have a research question: does smoking during tuberculosis treatment affects treatment outcomes? And the objectives were to find out the effect of brief smoking cessation package on quit of smoking. This is one. In new smear positive registered pulmonary TB cases. And the second objective was to assess the effect of smoking cessation package intervention on treatment outcome of NSP cases. So these are the two objectives I kept in mind before we conducted the study. Our study design was two-arm parallel double-blind cluster randomized controlled trial. We found few studies which have either cross-sectional design or a cohort design. So we thought of doing a cluster randomized controlled trial, and we selected all tuberculin unit in one area of northern India. That is, we took 3 TUs. These are the only 3 TUs which are there in Chandigarh, from where I belong. So we took there, and in our country we have designated microscopy centers, DMC we call. It's a health facility with TB diagnostic facilities for new smear positive cases. So it is the place where all the sputum are basically tested, and we take DMCs as the cluster units, and the cluster would define the DMC so that there is no contamination between the different arms. The study population was pulmonary TB patients who enrolled in DOTS in 2 quarters, that is over 6 months, to all those new smears positive patients, pulmonary patients, between January and June 2013 in different DMCs. We enrolled those, and the sample size which was calculated was 685. It was based on the assumption that smokers are more likely to default as compared to non-smokers based on several study findings. A power of 80 and the alpha error as 5%, and some attrition rate of 10% due to deaths, migration and incorrect address. So we see the next table. The TB patients are classified into smokers and non-smokers. So what we did is, we in these 3 TUs, 1 TU we have provided training of the healthcare providers. So in this project we have not kept the special providers to actually deliver the treatment. So we actually inbuilt this into a primary healthcare system, and we provided training to the existing health workers, because it's a simple package of 3 to 5 minutes, and the existing worker who is giving the TB treatment can easily administer this package, because they are already administering some of the advice under routine DOTS program. So in one of the arm we have trained them on delivering ABC package, and the second arm we have those patients are being given the routine care, the routine messages which these providers provide to the patients. So these are basically the standard smoking cessation intervention. Everybody is aware of the ABC package for tuberculosis. I'll not elaborate on it. It is ask, brief advice and cessation support. and it is delivered to from 2 to 5 minutes systematically, and it's a tailored package. Basically, it's not a very standard package. It depends on the patient, and they are being given the package depending on the type of the patient. And it is delivered at the time of registration of patient and during all the sputum examinations at 2, 5 and 7 months. So again, you can see there is no additional visit which is being made by the patient. So there is no inconvenience to the patient. They need not come back. Secondly, there is no inconvenience to the healthcare provider, because they are in fact giving the TB treatment on that point of time, beside giving the doing the sputum test. So these are the 17 TUs which were selected, and there were total 685, I told. Out of 685 new smear positive TB patients, 153 current daily smokers were there. So you can see a good proportion of TB patients were smoker. So we did a randomization. This was a cluster randomization. We didn't do a random, the simple random technique because of contamination bias, to reduce the contamination bias, although it is less rigorous than the simple random. In the intervention arm, we have 78 smokers, and similarly in the comparison arm, there were 74 smokers. So I will not tell the results over here. And we did a 6 months follow-up then. So you can see the baseline characteristics of the study. Despite a cluster randomized controlled trial, we can say that the result of the study were good, because the baseline characteristics of the intervention arm and the comparison arm was almost same in terms of gender, in terms of education, occupation, and the time after waking to first cigarette. So all characteristics which can confound the results are almost similar. The quit attempts in the intervention versus control arm, again we'll surprised to see similar findings which was shared by the previous presenter was here. And see, the quit attempt in last 12 months was in intervention arm, it was 61%, but even the comparison arm where the things were happening on their own, there were 56%. So we can see that there is no difference between the participants in both the arms with respect to different characteristics. Now if we see that the comparative analysis of the impact of intervention, how that over a 6 months time, how that intervention impacted, because there were 4 contacts of health worker with the patients. So if we see the proportion, the adjusted odd ratio are quite high. So we see there is a definite impact. Like if you see the first line, intervention versus comparison arm, there is almost 1.5 times more chance of being quit as compared to the control arm. So number of quitters were found to be significantly higher, 82%. This is quite high as compared to the comparison arm. So effect of the intervention was found to be insignificant between the groups for treatment outcome. So this is one surprising finding which we found, and we are in the process of following it. And we'll be sharing the result. We are compiling the results of the long-term treatment outcome of those patients who actually quit smoking. So whether they are really quit after a certain point of time, because this is the result after 6 months. So some of the strengths were like we involved the existing health worker force. So if we want to deliver this type of package in our healthcare system, so we need to work with the same health workforce which is already there. And all the TUs in the study area were enrolled, so it was a universal sampling, so there was no type of bias which can be introduced. But there were certain limitations because of certain constraints in the resources. We approached in the intervention group the family members to ascertain the reported status of smoking. However, in the control arm, we relied on the response of patient. So again, these are the two things which actually concerned us, and there is a possibility of contamination bias even after the cluster randomization, because it's a small area. So despite that, we can have some contamination. So which may have resulted to such accelerated response in the control area. So we conclude that the interventions such as ABC package that are based on the principle of stepped approach of health promotion have been useful in reducing smoking practices, and we should have more prospective study, longer term studies I think this is a good fora where more multicentric study should be there, so as to have a definite evidence of more quitter rates by this ABC intervention packages. So thank you very much.
Thanks.
More
Sure.
of a point of clarification. You said it's a cluster randomized trial, and you had 17 clusters? Or did you have
17 TU, no, it's 3 clusters basically. 3 DMCs. DMC is a unit where the testing is done, but under DMC we have tuberculin units, TUs,
Right.
where the patients are registered and getting the treatment basically. So there the sputum sample is not being tested.
Okay, so you have 17 units up there,
TUs, yeah.
TUs.
This is
that's how you divide. 9 got intervention, 8 got the comparison arm. Within those 9 units, you only had 78 smokers, and within the 8, you only had 74 smokers?
In that period, in which we enrolled, 6 months period.
Very small numbers for a cluster randomized trial. Did you analyze this? Is your analysis at the cluster level? Is your analysis at the individual level?
It is analysis at the cluster level here.
Really? Okay. I'm sorry, the numbers didn't seem to be
Yeah,
that way.
it's a small number. I think we can't definitely, because again there's a high smoke trial, so we can't definitely have an evidence that because this is just a sort of a pilot which we did in that smaller part of our country.
No, I understand. The analysis. Go ahead.
Sorry.
Just a point of clarification. First of all, thank you for the presentation. You said double-blind post-randomized control trial. I couldn't understand how we have a double-blind post-randomized control trial for behavioral intervention. Because of course you cannot blind.
No, like for example, double-blind in terms of the health workers who are actually, the workers are given the package, but they are not being told that they are giving the package, because it's everywhere we are told them that they have to give the package. Neither the patient is aware of that they are being giving the package, and only the worker who is administering the package know about the intervention. The analysis person who is doing the analysis
The analysis is blinded only. So only the analysis is blinded,
yeah,
right?
analysis, yeah.
The previous part, all the previous is unblinded completely. So
It is, yeah,
You
because
cannot
yeah, it's type of behavioral intervention, so it's difficult to blind. Yeah.
please.
Good presentation. The thing that I'm always challenged with when I see smoking and quitting and smoking and cessation is, what does it mean to quit? I'm sure these people quit every day, but then they smoke the next day. So, I want to just get into the definition of how you defined what a quitting event meant. And if you could elaborate on that, because I think that would be helpful in understanding these outcomes. And then even longer term, what does that mean in terms of TB outcomes?
Yeah.
I think there's another session, unfortunately, after this one. So
Just to shorten it out, I think it's a wonderful question. Yes, you want to? We have kept an operational definition of 3 months. Basically, if a person actually quits for 3 months.
So no smoking for 90
No
days.
smoking, yeah.
Measured by self-report, or
It is measured by the self-reporting.
But there is an international standard called Russell standard, which 6 months continuous abstinence, which is validated by biochemical.
Yeah. So I think that's why the smoking rates was a bit, this quit rates was higher, maybe. That might be the reason for that.
okay.
Thank you very much.
Thanks very much, and thank everyone.